Anyway, I think we're gonna get started. We're gonna get started. We have a couple of minutes for the intro slides. I'll cover a couple of things and then we'll get going with the talk. So here we go. Opening slides. Yeah, welcome to our care home Echo. And as you know, free, convenient, getting continuing education credits, opportunity to learn from each other. And thanks to our partners, Aloha Care and United Healthcare. Next slide. For any cases that you present, don't share any patient names or birth dates, and your questions can be anonymous, as is your chat. If you want to chat directly to either Juliana or Layla, they will be monitoring the chat box. Next slide. Of course, you know how to use your chat tool. Enter your name and others joining with you today. And of course, click on mute when you're not speaking and unmute when you want to share. Next slide. And today we are talking about reaching goals that matter, and in terms of our functioning and our mobility and things like that. So we're going to talk a little bit about challenges to that. And I also just want to point out that we are, after this session, we're going to take a break in November and December next month and the month after. So have a wonderful holiday season, and then we're going to see you in January. Okay, next slide. And as for continuing education credits, after you register, you can there will be a link for an evaluation at the end of this session. Make sure you click on that and you can access the forms and get the continuing education credits. Next slide. Okay, and here we go, introducing our team here. That's I'm the course director for the Echo Geriatrics Care Home. And Karen Lubomir, Dr. Lubomir is here, and she's going to be sharing the topic today. And we have Lynette Gaylord from the Care Home Operators Association, and Maribel, if she joins us, from the Foster Family Homes Association. We have Juliana from Aloha Care and Layla Ventar from United Healthcare. Thank you, everybody, for joining us. Oh, and today we actually have folks from Alzheimer's Association as well. We have Ivy Castellanos and Tanya Hammond. Thank you also for joining us.
Hello.
Okay, all right. And we also have another guest. We have Kristen McManus. You remember her? She spoke to us 2 sessions ago, and she's our physical therapist from occupational therapist from PT Works. And so she's going to join our conversation as well. So that's very exciting. I always like to get word from the experts. Okay, we're gonna just take like 3 minutes, right? For deep breathing. This is a really good way to de-stress really, really quickly. So next slide. Actually, I'm gonna have John turn on this video. It's a 1-minute video. Just follow along. John?
Let's take deep breaths today using the shape of a triangle. Put your finger on the start here, and then trace and breathe in for 3, hold for 3, and then breathe out for 3. Breathe in for 3, hold for 3, breathe out for 3. Breathe in for 3, hold for 3, breathe out for 3. Breathe in for 3, hold for 3, breathe out for 3. One more time. Breathe in for 3, hold for 3, and breathe out for 3.
All right. Thank you. So short and sweet, but I think it can really help us ground ourselves.
Don't forget about spelling and grammar mistakes. Just click on the
Turn that
highlighted
off.
areas in Grammarly's
All right. And next slide, actually, we're going to do another short video on COVID Corner. And this one is just a little COVID update from the Department of Health. And so John is going to bring this little video up as well. And the idea behind that, of course, is even if you've had a COVID infection, the antibodies you produce are going to lose effectiveness over time. And there's actually more variants out there. So therefore, you can get reinfected again. Just because you got infected doesn't mean you're immune forever. You can get reinfected again. And the percentage of COVID reinfections are increasing. So just want to let you know that the new bivalent boosters are out there. They target all the Omicron variants, and it will protect people from getting severely sick, even if they get COVID. So yeah, go ahead and just play that video. And it's also
from time to time, we hear
short.
people say that they're not going to get a COVID vaccine or booster because they have already had COVID. They think that a prior infection will prevent them from getting sick again. Unfortunately, that's not true. A recent infection can help your body produce antibodies, and it can help protect you. But that protection diminishes over time. You can get infected again. Take a look at this graph. The tall blue lines represent the total number of cases reported to the Department of Health from December of 2021 through September of 2022. The orange at the bottom of the blue lines represents reinfections. Most cases are first-time infections, but reinfections now account for a higher percentage of the total cases. Here's another chart. The orange line represents the percentage of total cases that are reinfections from January 2021 through September 2022. There weren't that many reinfections early in the pandemic, but over time, the percentage of COVID reinfections has increased. As of September, about 10% of total COVID cases are reinfections. The good news is that vaccines, including bivalent boosters, help protect people against severe illness, those infected just once or more than once. That's why healthcare professionals recommend you stay up to date on your vaccinations and boosters. Mahalo for watching, and we'll see you soon.
All right. Thank you very much, John, for sharing that update. Okay. And now we're just going to get started on the topic at hand, which is reaching goals that matter and utilizing an interdisciplinary approach. Dr. Karen Lubomir is going to be speaking with us. Well, actually, just using Cody's slides. That's okay.
I have different slides.
Oh, you do. Oh,
I do, because this is a person with nursing.
That's right. So do you have it? You can share?
No, I don't. I sent them to you.
Okay.
Yikes. A couple weeks ago. Sorry.
Yeah. Sorry about that. Okay.
While you're looking for the slides, I just want to introduce the topic.
Okay.
And that's having goals. Just starting personally, you woke up this morning and you had goals for the day. You thought about them. And you may or may not get to the end of your day and say, oh, I reached that goal. Just like that, your residents, our residents have goals. They might not be able to articulate them. Perhaps their family member or loved one can help articulate them, but there are goals. I guess the first thing is to find out what those are. And that's been some of the, either it came as a part of a care plan or a management strategy. The case manager may have discussed that. There may have been a family meeting to come up with those. And then looking at those goals, there are going to be challenges. Like this individual is living with you or in your home because they have challenges. So part of this talk is about finding out what those goals are, which I think we've already been doing, and then coming over maybe any of those barriers. And we can't do it alone. You can't be expected to do everything to help them, reach that final final goal. So I always say that when I meet a new individual and patient, and we identify goals, it takes the entire team to remove barriers, to set up realistic expectations, because some of the expectations might not be real. And the steps to those goals are baby steps. They don't just go from wanting it to achieving it. And this talk is going to be about, like, how do we take a case and sort of look at that and figure through that. Are you able to find them?
Oh,
Say something to you.
and I know.
Possibly to John as well. So
Yeah.
everybody take a more deep breathing.
Okay.
I can read. I'm not on a computer. I'm on my iPad.
Okay, sorry about
I know Michaela saw them.
This is Juliana. I just forwarded you the reaching goals part that Dr.
There.
Lemire sent
Oh,
earlier in the
good.
week.
Thank
Okay.
you.
The one with
Great.
edits. So look in your mailbox. It should be there.
that. Okay, sorry about that. I am,
I sent them on the 6th. Well, I don't know where I sent them.
oh, okay, sorry.
Thank you.
Whoever can pull them up first would be great. Because it's not slow in arriving in my inbox.
Can you guys
Okay,
see?
yes.
There we go.
Okay.
That looks
Let
better.
me-
Okay, please go ahead. And then when you reach the end of it, then we're gonna get back to our other slides. Okay, John, because we have a few housekeeping things to take care of the last 15 minutes.
Sorry. I'm so
Just
Just let me
sorry.
know when
Thank
the
you.
next slide, Dr. Lemire.
Oh, thank you so much, Juliana.
Thanks.
Okay, so I'm giving credit to Dr. Takanaka because she also, started this process, and her talk is really for residents of long-term care facilities or rehab facilities. So this is reaching goals that matter using the utilizing your IDT approach. Next slide, please.
Hold on, I'm trying to get control from my end.
Oh,
Hold on.
take control from Juliana.
Okay, that would explain why I couldn't control it.
Oh, is this from Juliana
Yes,
sharing?
yes.
Okay, I can make you the co-host then.
Okay, that's fine.
Great.
All right, there you go.
Thank you. So it's real life. I think that's a great place to start. And I think Mrs. K is quite representative of what we all someone we might meet. So just to look at this case, she's a 75-year-old female. She has underlying medical problems, common diabetes. She's had fainting spells or syncope, depression, and she has pain. She came to a medical foster home about 2 weeks ago because she was too weak to live alone. She had been living on her own prior to this. She now with you, she does not want to get out of bed for any of the home physical therapy that's been ordered for her. And she really doesn't even want to come out of her room for any of the activities. So what we're hearing is she's making absolutely no progress with her therapy. Her family does come to see her every week, and she seems quite angry and actually upset most of the time. Maybe this is a familiar case. Where do we go? What are we going to do? How do we discover, what her goals might be and move forward, progress? Next slide, please. So this is something called root cause analysis. So she has these problems, and we want to find out, which I would say are the leaves up at the tree. We want to find out down in the roots of the tree, what is the root or the cause of her problems. So we're asking why certain things. So next slide. She's not getting out of bed. That's a problem. She's not able to weight bear or transfer. Next. She feels uncomfortable. She's either in pain, she just doesn't feel well. She's tired. She's unhappy. And she wants to stay in her room. Those are the problems that you're seeing. So what's causing these things? What might be? So we're going to explore the causes, and those are the roots of the tree, or the root of the problem. And we need to find out what that is in order to help Mrs. K move forward in her life to have quality of life, and maybe to determine what her goals are. So asking why. Anybody want to hazard a guess what might be causing any of these problems? What are the root cause or the causes potentially? Somebody can monitor the chat.
I don't see anything in the chat yet.
I don't see anything either. Okay, so all right, why don't we just next click. So let's take number one. She's not getting out of bed. Well, perhaps if we look at the root cause of number one, could be pain, could be she's quite fatigued. She's been perhaps in the hospital. We heard she was feeling weak. That's why she couldn't go home. So perhaps that's something we need to address. Next. Number two, she's not able to weight bear or transfer. Well, one of the causes, she's refusing physical therapy. So how are we going to get there if she's not wanting to participate? Next. She's uncomfortable. Maybe that's because she has arthritis pain. Perhaps she's constipated. She hasn't had a bowel movement in days and days. Number five, she's unhappy. She feels her family left her there. And then one more. She's tired. She's not sleeping well. Maybe it's very noisy, or maybe maybe she shares a room and or somebody next door has a hearing problem and the noise level is very high, or maybe they're calling out or have delirium or dementia and they keep calling and asking for attention, banging, whatever. So that's causing poor sleep. Next. Or there may actually be she's wanting to stay in a room. Maybe there's overlapping causes, and maybe when we look at these causes, there's things that affect more than one of these problems. So this root cause analysis is just a way to mark out what the problems are. Those are the leaves in the tree, and then kind of dig down at the underground or what's not obvious and say, well, here's what might be causing that. And then maybe then we can start to address that. Next slide, please. So, oops. So this is a fish diagram, and it's a schematic of a way that, afraid of falling. Thank you, Annette. Yes, afraid of falling. She doesn't want to get to bed. She's afraid of falling. She's not been walking for several weeks, so she's deconditioned. Thank you. I guess maybe I'm moving too fast. Can you go back one slide, Barney? There you go. Anybody else? I got 1% of chat. Anybody else? Are there ways that you might address any of these causes? Is there any suggestions? And this is from our IDT members that are here as well. Things that you want to address? Pain. Oh, Dr. Wayne wants to address her pain. Oh, her family. Maybe talking to her family. So she's unhappy. Maybe if somebody was there when she was getting her physical, maybe you could coordinate the family visit perhaps when she's having her physical therapy, and that might be encouraging to her. Thank you. Encouragement through treats. Okay, I like that. Why not? So maybe that might be a way to address some of these. And maybe the timing of her therapy, or her schedule is not the schedule that's operating within your facility. She's not a morning person, and activities are starting. And Lila, thank you. Can we find out what she was doing at home? Can we make that match? Maybe more? Maybe that would be something. She's been plucked out of her known environment and is asked to live in a certain situation. Lynette's suggesting maybe home physical therapy isn't the best. Maybe encourage her to be out of that setting, have other stimulation. And OT said something about focus on her ADLs or leisure interests to get her going. So as a way to motivate her, finding her pleasurable activities and making them a part of her therapy sessions might be more encouraging to her. These ideas. Excellent. I know all of you, I came to the depression echo, and I know, so I might say when I look at her unhappy, she's feeling left, her whole world is turned upside down. Maybe that we need to be evaluating for depression. I mean, her depression needs to be managed or treated. Yeah. Okay. Thank you. All right, next slide. So a couple other things that when looking or trying to find out and discover what's going on, why is she not meeting sort of these goals? There are a lot of suggestions is looking for ways to motivate her, find out. There are certain staff factors, patient factors, environmental factors, or rules or policies. I'm not sure why the slides are doing this, but I'm getting, extra little phrases in there. But that might lead to no progress. This is another way, different than root cause analysis. This is another schematic and way you can think about things. So here are some staff factors. You can just advance the slides. Click. So the staff, she's grouchy. She doesn't want to interact with people. And maybe, okay, if we just let her be, it just should be okay. Let her on her own a little bit. So there's not as much interaction for her. Other staff factors may be playing into this. It's been a really busy week, perhaps at the facility. Many residents had doctor's appointments. There were multiple admissions, perhaps. People were distracted from paying her as much attention. We talked a little bit about this before in that other diagram. There's a resident who's hard of hearing and is yelling, has a lot of TV or something. Okay, next. She calls out when she needs something. So she's kind of, she can't communicate well. So she's always sort of seeming to, have outbursts because she's, wanting something or some help. So, not getting her needs met might be an environmental factor that's playing into her lack of progress. Patient factors, can you click again, please? She may have back pain that's uncontrolled. I know Dr. Lynn, so we had said this, why isn't she getting out of bed? Why is she wanting to stay there? Or why is she not able to wait there? She may feel sad or anxious, about not being able to return home, knowing that this is now her new place that she'll be living, hopefully, perhaps for her remaining days. And, that's something to be addressed. She may have constipation, as said before. She's very uncomfortable, so she's not willing to participate. Under rules and policies came up, all the staff is wearing masks. She can't, we don't have that social engagement that maybe she was so used to at home. Her family would come in and she'd see neighbors or something. But now here, because of policies, everybody's wearing a mask. Or perhaps in the foster home, there's been a COVID outbreak. So everybody has to stay in their room, even further isolating her. These might, again, when we're looking at this, the arrow on the right, which says no progress, might have to look at many different factors and how these are intersecting or overlapping to her not meeting her goals or the progress that we'd like to have her make towards being more independent. Next slide. Okay, so we're at PDSA. I think that's probably familiar to some people. Planning, I'm sorry, so plan, do, study, act. So let's click the first one. Okay, so planning. Why, clarify, why is she there in this living situation? What were the things that brought her there? She wasn't able to live on her own. Thank you. Not able to live on her own. Has anybody asked her about what she'd like to do? I know occupational therapy team member said, clarifying what gave her pleasure. So what are her goals to going back to those activities? We need to be treating, making sure she has adequate pain control. If she's constipated, we manage that. And how do we improve her sleep so that means she's not so tired in the morning? If we're going to do the D part would be optimizing her therapy goals and the timing. Dr. Wynn brought up that perhaps she's not a morning person. Somebody else had suggested what is her normal routine, or getting her, having her leave actually the setting and going somewhere so there's more interaction in a community-based physical therapy or occupational therapy. Doing also be following up with the physician to monitor things like if there is depression or again uncontrolled pain. Another something we do would be monitoring the resident noise level and then encouraging good sleep hygiene. Studying, so looking at the progress that she's making. So setting goals with her and the family to meet those benchmarks. What is the progress? So that she can achieve whatever her functional goals are. Also making sure that every day that pain is being addressed. So there might be some pain scale that you might use, or activity level or functional level that shows that her pain is controlled. If constipation is a problem, monitoring her bowel movement or patterns. And then also what hour how long she's actually sleeping at night or during the day, which might, yield poor sleep hygiene. And then we have this fatigue cycle going on. And then under ACT, just keeping everybody appraised of how we're progressing towards the goals would be important. So they can maybe readjust if we're going slow, or if things are progressing more rapidly, readjusting those. And then the same thing with medication treatments. Are they effective? Are there side effects that are cumbersome, or the patient, the resident doesn't want to take the medication? And then lastly, making sure that there are activities that she is excited about or wants to do each day. Thoughts about this? Next slide. Oh, okay. Oh, a lot of clouds. Okay, so we've come up with this lovely PDSA. So my question is, who's going to follow through on each of these tasks? There are a lot of items listed there, and there are a lot of things. whose responsibility or who's going to follow through? The team in charge. Thank you, Juliana. The team in charge of her care. So if you made that plan, there are going to be different team members who are going to check in with the nurse case manager, physician, OT, PT, if she's got speech, recreational therapist, whoever else is involved, family members, might all be given a role in this. Thank you. Next. Just click again. I think another cloud will fill up. There we go. Who's going to be involved or updated? Would be important as we're moving forward for Mrs. K. How are you going to do that? Patient and the family. Okay, absolutely. OT, PT, everybody. So how often would that happen? Does anybody? Ideas? How often you want to see this happening? Oh. Quarterly, okay. So quarterly might be realistic.
I would be worried that that'd be a long time. Maybe. Yeah, I would, if they're really not moving, maybe every week or so until we can figure out what the problem is.
Okay. So a higher intensity, more frequent early on, and as goals are being met, then maybe spread that out. Okay, so the who and the when. So a lot more intense, right? When you first have somebody come to your residence, to the foster home or care home, it's very busy getting to know them, understanding, and there's a lot more contact between members. Okay, so I like that suggestion. More frequently early on. And then how are we going to circle back to them? Somebody said, so just a quarterly meeting. Is there a check-in point with case management or other team members? Family meeting with the team. Oh, I like that, Julia. Thank you. A family meeting. Then everybody, all the stakeholders, everybody who's an interested participant can sit down and hear the same thing. And if there are discrepancies, if somebody said, oh, it's not quite like that, then you can share that at that point. And then it also gives you a chance to set new goals. Okay, we didn't quite reach this one. How are we we need to shift or change a little bit and reestablish goals. Okay. Other thoughts about this process? Oh, it's continuous. That's this little diagram. It's not going to just, we just get together once, we plan it, we do it, we say we act on it, but likely this is going to entail multiple or several cycles to getting towards a goal, and maybe perhaps a changing goal. Maybe instead of standing up, it's just going to be sitting out of her room. Oh, we can have our care plan updated monthly. Oh, my case manager. Okay. And then so we continue this cycle, and it continues to focus on patient-centered goals and what interventions can come up. Exciting.
I love how Eliza said, talk to the patient.
Oh, okay. I missed that one.
Yeah, right? Isn't that the most important thing?
Thank you.
She's probably going to tell you how to improve the situation.
Right. We do hold the answers. We do. Right. So we're going to focus on patient. Yes, patient-centered. There we go. Patient-centered goals. Challenging because when she came angry, upset, uncomfortable, in pain, perhaps depressed, or at least situationally depressed, she's just had a huge life change. So her goals may look very different that first week or 2 weeks than they do a month or 2 months out when you've addressed or begun to address those problems. And just know how it looks today is not necessarily how it's going to look a month or 2 months from now. So again, that continual recheck in and several cycles, this spinning diagram shows that this is ongoing as they change. Thank you. Any other thoughts? Thank you for the team for jumping in.
Thank you. So yeah, I'd like to hear from Kristen. What kind of tricks she has up her sleeve if people refuse to do therapy? What do you do?
Yeah, so I'm Kristen, the occupational therapist. Yeah, we encounter this often. So in the comment section I mentioned, right, like getting back to the basics, we often, in OT anyway, can really get a going when we bring up the ADLs, like, okay, no exercises today. Okay, what about if we just get you ready for the day? What if we just brush your hair? What if we just get you dressed? And as we know, those things for a lot of our residents or, those who we're caring for, that can be exercise in and of itself. It's important to, like we mentioned, find out what their interests are. We also need to take into account kind of the residents or those who are caring for their kind of sensory systems. Like, are they hearing us okay? Can they see, what we're presenting to them? A lot of times we start lots of exercises, and sometimes we're kind of bombarding them. Hey, get up, do this, do that, and we really have to kind of slow down, maybe create a schedule of what we're going to do for the day, write it down, let them kind of feel in control, maybe giving them some more choices. A lot of times in whatever setting they're being told kind of what to do or asked to do a lot. And sometimes it's just, as someone said earlier, listening to the patient saying, hey, what do you want to do today? Or, hey, I have these two choices. Which would you prefer to do? So those are when we encounter a more refusing pattern therapy. And then up on the screen here, this is something that we in therapy really like to do. It's fall screen. And so this is a very simple and quick way to see if the resident or your patient has a fall. As we know, when a resident has a fall, they're more likely to not want to get up and move. Maybe that's what happens to that resident we had the example before. There's such a fear afterwards. So doing a fall screen, doing these quick little assessments, see if they're at risk of fall, and then we can therapy step in, give the strength or coordination or the change in the environment that the resident.
Thank you. Okay, so Michaela, you are joining us right now. So I'm wondering if you can actually just go back against the slide, one slide back, John. Yeah, so for everybody here, we know that you've been really good and sharing with us the documentation of how many people in your care home are screened for sit to stand and time to get up and go test, and the number of falls in the past month. You did that at the beginning of this mobility series. And so we're asking you to do it again now after the series is completed, because we want to see if the numbers went up. So we want to demonstrate that you guys are doing a good job helping residents achieve their wishes and get stronger. And I just wanted to give you a tip. If you forgot how to do these, you can review the videos from the July session because it has the little demonstrations for that. Okay, next slide. And I'll let Michaela take over here.
Yeah, so these were our pre-screening results. Thank you, everybody that did submit these numbers. I know I've said it before, but we are grant funded, and having metrics like this, having data like this helps us continue our funding and continue to be able to provide you education. So it's really helpful, and it helps us show our funders that you guys are doing a great job. And these numbers were really excellent. 85.5% had done a sit stand with their people. Why not talk story first, right? Timed up and go is a 65.3%, and there was only one fall, which was amazing to see. John, you can forward one, please. If anybody ever has questions about these evaluations that we're doing or needs help completing their evaluations, I am open to office hours. This week I will be on at 10 a.m. on the 26th, or you can email me. Usually I do the Friday after and the morning after, but I'm out of town right now, so I have to adjust it. Go ahead and go to the next one, John. So back this summer, we asked everybody to complete these these care home needs assessments. So I'm going to show you some of the results from that right now. Thank you, everybody that did complete these. We had most of everybody that, well over 50% were from foster homes. And a lot of people had done over 10 years or 5 to 10 years working in these foster homes. So that's a lot of years of experience under your belt and a lot of commitment to what you're doing. And we thank everybody for the amount of work and time that you have put into your work and into your residents. Yes, that's dedication. Go ahead and forward another screen, John. So this was the caregiver burnout survey that we asked you to do. And overall, we saw really great results from this. The question, do you feel you don't have enough time for yourself? 45% said sometimes. Do you feel overwhelmed between caring and meeting other responsibilities? 43% said sometimes, 17% rarely, and 22% never. Do you feel your residents affect your relationship with others in a negative way? 57% said never, which is great. Do you feel stressed when you are around your residents? 45% said never, 30% said rarely, and 21% said sometimes. We only had 2% said quite frequently, and 2% said nearly always. Do you feel your health has suffered because of your involvement with your residents? 56% said never. And do you feel you have lost control of your life because of your caregiving responsibilities? 57% said never as well. Next screen. Here we asked what services you currently use, or if you're not using them, you would use. Home assistive devices, 92% said they are currently using. Personal emergency response systems, 69% currently use. Transportation services, 60% said they currently use, and 31% said they would use. Workshops or seminars, 56% said they currently use. Workshops and seminars on taking care of yourself, 45% said they would use, and 45 said they currently use, and 46 said they would use. Caregiver support groups, 47 say they currently use, and 43 said they would. Recreational therapy, 50% said they would use, and 36% said they currently do. Music therapy, 57% said they currently use, and 38% said they would use. Legal services, 53% said they would use. John, next slide. So, and the concerns that we saw were ensuring the care recipient safety. 55% were very concerned about that. Balancing other family responsibilities, 41% said they were. Ooh. My apologies. We have.
Okay, we lost audio.
Michaela is having a fire alarm. Oh my goodness.
I
Okay.
like that the very concerned is in red. I like that you can see those ones that are kind of glaring out there.
Yeah. Actually, so I'm gonna, while we're waiting for this fire alarm to be done, maybe the next slide is actually Alzheimer's Association.
Sure, that sounds good. Thank you, Dr. Wen. And hello, everyone. My name is Ivy. I'm from the Alzheimer's Association, joined by my colleague, Tanya. Thank you for letting us join today's meeting. And to echo what Dr. Wen and Michaela mentioned, such admiration and gratitude for what you all do on a day-to-day basis, you know, and caring for your residents. And gosh, just to think of the impact that that has on their lives and their families' lives. Talk about dedication. So mahalo truly for that. And, you know, at the Alzheimer's Association, we just want to sort of make sure that you're taking care of yourselves too, and honoring your needs, which is equally, you know, as important as caring for others. So where we can help, you know, is with resources and support, and perhaps creating some opportunities for self-care, like this support group here. So we saw with the survey that there's some interest in caregiver support group, and I believe in workshops or seminars as well on self-care. So if we could maybe press a little further and ask just a couple more questions so that we have, you know, a clear sense of what would be kind of most helpful and most meaningful for you all. I think that would be great. Let's see, I'm going to ask John if he might have the polling questions and be able to run those.
Okay, I'm gonna start it now.
Okay. So yeah, if we could ask everyone to kind of keep in mind two things, the workshops or seminars on self-care, as well as the potential, you know, caregiver support group. If you guys could help kind of clarify, you know, what would be sort of the ideal meeting format? Would it be kind of most helpful to do something virtual like this, or something in person? Or if it's, you know, an education you know, program, would something sort of on demand be most helpful, where you can kind of go back to it and access it whenever it's convenient with your schedule? What is the best time of day? Would you attend if they're, you know, without any CECs, CEUs or CMEs? What we really are interested and curious about is there anyone here that might be interested in sort of helping us facilitate a support group, you know, to your peers? We do have an Alzheimer's Association caregiver support group facilitator training. So that is certainly an option. We'd be happy to partner, you know, with anyone who might be interested in sort of facilitating, you know, this to this group here.
I'll just add, Ivy, that I think having someone that is in the trenches and understands what you guys go through, because if I were facilitating and helping lead the support groups, I may not really understand everything that you guys are going through. So if any one of you feel that you think that you might like doing that and helping your peers in that way, we can definitely help you with knowing how to kind of make that work. So yeah.
Yeah, absolutely. And then finally, the last question, you probably completed this already, but is there any interest in kind of adding a social component to a support group where perhaps it's meeting for coffee or coordinating, a quarterly potluck or something along those lines? We know that, interacting with colleagues is an important thing. However, we know that there are huge demands on everyone's schedule. So we certainly want to be sensitive to that and honor that. So looks like the polling has commenced or has been completed. So we thank you, everyone for your time, and we'll look forward to kind of reviewing those results and seeing what makes the most sense. Let's see, it looks like, a virtual meeting would be the most convenient for everyone. Weekday looks like it might work best in the afternoon. Okay, so yeah, the credits, okay, that's not as huge of a factor. I'm interested in support group facilitator training. So if you fall into that yes category, Tanya, if I can ask you to maybe type in our contact information. And if we can ask you to please reach out to us, we'd love to just kind of connect and, talk with you a little bit more about the next steps for this and what this could potentially look like. And yeah, social component, yes. And I think I saw a comment about how we love food, right? Don't we? So if there's a way to incorporate that, we'd love to be able to do that. Tanya, is there anything else you wanted to add? I know we're sort of pressed for time.
Yeah. And I think Juanette has my contact information if anyone wants to, if you weren't able to see in the chat my information. But yeah, we just want to help you guys. I know that it's what you do. I was thinking about the first presentation that the doctor gave about the trees and then the root, and I was just thinking about you guys and all the things that you have in your life, and then the root cause of all that. And we just kind of want to help with that part, with that root cause, and help with making your life a little better, and just being around other people that you can just kind of hang with, and just even kind of have a little, maybe just a tiny gripe session, not a lot, because we want to be positive, but just to have those emotions that you're feeling and things like that validated, and we're here to help. So we are looking forward to helping you guys. Seems like it's been a while. We've tried to do this before, but we are determined to help you. So thank you so much.
All right. Well, I just want to say thank you to everybody here. Thank you to Dr. Lubomir for presenting. Thank you for our colleagues over at United Healthcare and Aloha Care. Thank you so much for Tanya and Ivy. And yeah, and just want to remind you that we are going to take a break for a couple months, but we will be in touch by email and let you know what's coming up. But we are probably going to do a little revamp, and we're going to try to get some of these support group things going. And we wish you guys the best, a really nice holiday season, and we'll see you all in January.
Thank you, Dr. Nguyen. Thank you, everybody. Have a great holiday season. Merry Christmas.
Thank you.
Thank you.
Thank you, Kristen, for joining us.